Hello, my name is Chandra Brown-Levy, and I'm here to kick off our presentation for the University of Colorado's Integrated Behavioral Health Plus model. And today I'm here with my colleagues to describe the work that we have been doing as part of a UPL project to expand on our model that includes both integrated behavioral health on the ground and through telemedicine. So if we could go to our next slide, we can kick this off. So we've been doing work in integrated behavioral health for several decades, actually. And through this work with UPL, or upper payment limit funding, we're able to expand this work in a really significant way that we're really excited about. We want to share more about how we're doing that today. One of the things we're really excited about is, in a very robust way, we've been able to expand our clinical work, and we'll share who our clinical folks are today in our clinical teams. Also, our administrative teams have been expanded through this work, and that's really, really important to lay the groundwork for successful integration. And then the other piece is having a robust evaluation to make sure that we're really measuring in a meaningful way what's happening both clinically as well as financially, to ensure that we're building a program that ultimately has financial sustainability. So without further ado, who are these people? So several of the folks on this slide you'll get to hear from today. And these are the trailblazers and leaders who are helping to set the foundation for a successful integration and a robust growth in all of our programming. So we're lucky to have everybody here today. These are some of the psychologists who have been working both in person on the ground throughout our work before our UPL. And then with our UPL, we've been able to expand, and we have Dr. Zissner, Dr. Lake, Dr. Kostiuk, and Dr. McCann. One of the things that's really, really exciting is that several of the people who are in this group were actually previous trainees in our program. And I think that that's sort of a exciting detail, because it means that not only are we training the workforce, but they like us enough to come on back. So we're really excited to have this robust team and to be really training and then bringing back the workforce. So some of the workforce has gone out throughout the country, and some of them are coming back and joining us to expand our work here. So very exciting stuff. And here we have part of our telepsychiatry and teleaddiction medicine team. And again, another testament to building the workforce. We have Dr. Brown, who is also a trainee of our program and stayed on to help expand our work. So very exciting. And also Dr. Klee is a previous trainee of our program and now is a real champion and leader as well. So very excited to have this robust and really highly qualified team to take good care of our patients. And the next slide, you can see our evaluation team. And one of the things that's super special about this program is to have such a robust evaluation team, and having both qualitative and quantitative components that we're going to be able to measure and add, and also have a health economist as part of this team to help us understand what are the core elements that we need to build something that truly is sustainable, and keeping our finger on the pulse of what is going on from a financial sustainability perspective, and what payers are willing to pay for, and what we need to do both now and into the future for many years to come. So we're very grateful that we have basically a powerhouse of evaluators with us. Like I said before, we also care a lot about trainees. So we have a APA accredited internship program that's one of the oldest in the country. So we have our interns, and we also have practicum students currently coming from 4 different area doctoral programs. And so they are amazing, and they are across 4 of our different sites right now. And it's always wonderful to have their enthusiasm and their fresh ideas that they bring every year to the work that we do. So this is a sample of the 10 trainees who also add to the work that we're doing. And some of them also go from practicum to internship and then stay on as faculty, or we can bring them on as faculty. It's pretty cool. So this is the vision of what we're trying to do. And I'll walk you through the why, the who, the when, the where, and the what. So why are we doing this? We have a strong belief that behavioral health is health. We usually separate the two, but our belief is that it really all is one. And one of the things that's really nice about having a robust team is that after training, oftentimes we get stuck in our silos, but when we're working together, we still get to continue to hone our skills and see how others practice, and that helps elevate everybody. So when we get to work together, we get to engage with one another and then provide better care. Also, we have a lot of patients that will never really go outside of primary care to get the majority of their healthcare needs met. And so when we can bring that care to them, they're most often to get their care needs met, and they can do that in an environment where they're feeling a lot more comfortable. So that's what we're trying to do. Also, we think that it takes a village in order to do this. And so it's really all of us. It's everybody on the treatment care team. It's our behavioral health team. It's our family medicine team. It's our nurses and our care managers and our social workers and our trainees of all different backgrounds. So it's really all of us. And at the center of that is our patients. So it's all of us. We started our UPL work in January of 2020, and we have 3 years to implement, but we're really lucky that we have a strong foundation from that work that we've done previously. So that's about our timeline. We're doing this across all 7 family medicine practices, and we're also helping with inpatient as well. But our focus is our outpatient group. And then we're going to talk a little bit more about what in our next slide. So this is a program that blends both telemedicine and on-the-ground services. We have a cloud-based virtual telemedicine platform that allows for real-time engagement with patients as well as other providers. And we have a stepped model for these available services. Sometimes that's an e-consult, so messages through Epic or our EMR for brief questions or chart reviews, and a lot of work can be done through that methodology. We also have provider-to-provider consultations. So these could be scheduled or they could be done on the fly to help people with brief questions. Co-consultations are a great way to really fast-track work and consult with PCPs, patients, behavioral health providers, and develop a plan together. And that can really fast-track the work that we do and make sure that the patient is always at the center. Our psychiatric evaluations help initiate plans, document recommendations for medication management and other management needs for the care plan. And interdisciplinary team meetings, especially for patients with high complexity, where everybody can put their ideas together and then work together so that we can share in what those complex needs are of the patients, share in ideas, and think about things that we wouldn't on our own. And then there's always work to do didactic education, and we can do that in a way that brings trainees together. Then that's even better. So when we can have behavioral health trainees, and when we can have our traditional medicine trainees, everybody together, it creates a really enriched training environment. We want to have structure but flexibility as well, so that we can have scheduled time to make sure we're getting the work done, but also when things pop up that we're flexible enough to be able to support each other in those times of need. So that includes warm handoffs, supervision, didactics, meetings, all sorts of different ways that we're working together to make sure that we're taking care of each other and our patients. And then we're coordinating with the team. So a couple of our different types of providers are listed here. So it's our social workers, our psychologists, health coaches, care managers, navigators, lots of different people on that integrated care team. We're working to make sure that we have full support for all of the patients we're caring for, over 60,000 patients across our sites, and these are our 7 different locations across the Front Range of Colorado. So it's a lot of patients to care for, but we feel we are fully up for the task. And in the next slide, and this is the last slide that I'll present before I pass this off to Dr. Shore, these are some of the lessons that we want to keep in mind and things that we've learned. And I think that the more we keep this in our minds, the better we'll do. We continuously have to, I think, take a breath and remember to have patience, both in terms of what we have to do as an organization, as well as change management. It takes time, and we're constantly educating ourselves and one another around this. Becoming part of the team is really important. So in a lot of instances, we have to operate independently, and we also need to remember the beginner's mind or a humility-based mindset with ongoing learning. So it's sort of the toggling between those two needs and shifting from traditionally the way that we're trained in this hierarchical organization to more of a flattened hierarchy or a team-based mindset. And oftentimes when we do that, when we remember that, we just do better with one another and we provide better care. And ultimately, relationships matter. All relationships matter with our teams, and it improves the patient care that we provide. So we all have different personalities. We all have our quirks, but understanding that, getting to know one another, remembering what our priorities are, and then remembering how important trust is across our teams. To help support one another, support our patients, support our clinics, and then all the while navigating technology, which is so much fun, especially during a pandemic. So with that, I think that concludes my portion. Dr. Shore.
Thank you very much, and for the wonderful opening remarks. So I'm going to talk a little bit about the overall structure of the specific project that's driving the principles you're hearing about today. So this arose out of the work that's already been mentioned that we initially started in one clinic, and now we're engaged in efforts through the support of a grant through CU Medicine in the state of Colorado to make integrated care services both in person and virtually available across 7 outpatient clinics to cover 60,000 patients. The services are aimed really at improving what most people may be familiar with is known as the quadruple aim. We want to, through integrated care, improve the experience of patients, both the quality and satisfaction of care, being able to receive behavioral health care in their primary care settings, leveraging that to improve the health of the entire population of patients that we treat within these clinics. We know that when integrated care is done well, there's a lot of evidence that shows that it increases the per capita cost of healthcare, creating savings, particularly on the medical side, which obviously increases the value of care, as well as practicing for all providers in these team-based, holistic approaches to treating patients. Brings much more fulfillment and joy and decreases provider burnout, which is a significant issue, particularly during the COVID pandemic. Next slide, please. So this gives a map again of sort of that the mission here, and you can see these are 7 primary care sites of varying size located all across the larger metro area of Denver, and including in some of the outskirts. And so being able to blend in smaller clinics, in particular, sort of the full complement of medical and behavioral health personnel together through virtual means, it both increases access to that type of care, but also the efficiency of the services we're able to deliver. Next slide. There are sort of 3 components, key components to this effort as we move forward. One is continuing to grow a workforce that is skilled and trained in providing integrated care. So that includes both recruitment, but also both the initial development of those skill sets, but their ongoing career growth and support. The second pillar is taking the model of integrated care, which you're about to hear more details about and how we actually execute it, but combining the workflow, which is sort of the playbook, with the teaming that's involved to execute that playbook, and so that is an ongoing process in all integrated care services. And then finally, building out the administrative components that are necessary: billing, tracking, the technology support. And it's much different than doing this in one clinic than doing this at a system level. So those are sort of the three pillars that we're pivoting towards as we build this project. And we have a very important evaluation team that you will hear about. And so our goal is to evaluate in an ongoing method, getting just in time feedback so we can iterate all of these aspects to continually to adapt them as we go to get them to a sustainable model. Next slide. And that is the end of my segment. I'll turn it over to Polly Davis. Thank you.
And what makes our project so special is that it crosses university departments as well as medical campus entities working collaboratively, unfortunately, during a pandemic. COVID job and health benefit losses are projected to increase Medicaid enrollment by 1/3 by the end of this year, which makes IBH Plus even more timely and even a bigger lift. This project will achieve integration through embedded psychologists on-site and virtually at each family medicine clinic, e-consults creating access to psychiatrists, and telepsychiatry services, which will give clinic providers additional specialized support for their patients. 8 months into our project, all of our clinics have at least one embedded psychologist. Which is wonderful, even in the smaller clinics, to have access to that level of care right now. Obviously, this has increased demand for psychology services as a result of COVID. And what's been happening is through a hybrid of on-site and virtual appointments with psychologists, we're able to expand access to psychology services, which has been really in demand as of late. Another component of our program are the e-consults, and the project started through Project Core, and it included all specialties, not just psychiatry, but psychiatry e-consults started back in March of this year, and they're being integrated sequentially with telepsychiatry services in our clinics. And as we add more and more clinics, we will add more psychiatry support to that to expand all our telepsychiatry services. And then telepsychiatry actually started 6 years ago as a pilot in our AF Williams clinic. And through cycles of improvement, the services will be in some phase of implementation by the end of calendar year 2021 in all of our clinics. Hopefully sooner than that, but we want to leave enough time in there so we're able to bring in additional psychiatry support. We also have an addiction medicine component that is running through our psychiatry and telepsychiatry program right now, which also is a benefit to our clinics. And while the key components of integration primarily center around the addition of psychologists and psychiatrists, there are other key components that are happening in the background. To make any project work effectively, you need processes, not just people, and those include creating standard workflows through revenue cycle analysis, frequent communication to all of the stakeholders, and creating a framework to support change management. Our telepsych coordinator and informaticist provide connectivity to those processes, and the implementation team as a whole. And these key pieces are surrounded by some less tangible but yet vital components of provider collaboration, experienced project and clinic leadership, the enthusiasm of the clinic staff, which is always important, support from the Department of Family Medicine and Department of Psychiatry, and of course, grant funding that makes this project possible in achieving the quadruple aim and improving the lives of our shared patients. And I will turn this over now to Dr. Jacqueline Calderon.
Thanks, Polly. Hi, yes, Dr. Jacqueline Calderon, adult psychiatrist. I have been working with this project for the last 6 years. When I first started as a pilot, I was the first psychiatrist involved. And the part I'm going to start with sharing is this: what are some of the basic principles that guide our model? So one is this idea of workforce multiplier. We recognize how the shortage and the limitations with regard to mental health access. So how do we multiply the workforce? The second is, how do we effectively leverage technology, doing that efficiently and effectively, as well as this idea of leveraging relationships. So leveraging the relationship of the primary care provider to the patient, where that could be a brief they just met or years and years of experience. How do you then leverage the relationship of the embedded psychologist to the entire clinic? So the family doctors, the nurses, the pharmacists, the social workers, the care managers, etc. Allowing for a stepped model with this team approach, so that there are different levels and different intensities of access available. So we allow for multiple synchronous as well as asynchronous access points to psychiatric care. And there's intentional and scheduled communication for coordination of care in addition to this, on the fly. These are kind of the driving forces and the driving principles that keep our team integrated. So I'm going to speak a little bit more about that integration. Next slide. So this was already discussed before. This is kind of the basic structure of what the stepped model looks like. Again, from the foundation of the embedded psychologist through this e-consult to a provider conversation to a patient visit and then didactic teaching. Next slide. So what does it look like? How do we grow the psychiatric team to meet the needs of 7 family medicine clinics, 60,000 patients? So this is what we're looking at for now. So in 2014, we started at AF Williams, and they have about 19,000 patients. And thus far, we are fully utilizing 0.6 of psychiatric clinical FTE. For Westminster, another clinic that has 9,000, we're looking at about 0.25 of psych CFTE needed. And then we have these 3 CU Med clinics with a combination of 6,000 patients, and it's looking like about 0.4 of clinical FTE. And what does that mean? It means based on the number of patients, but also the need, the severity, the number of Medicaid, a different amount of psychiatrists is going to be needed and distributed in that way. Next slide. Okay. One of the fun parts about being a psychiatrist and leveraging some of the expertise is getting to teach not only the patients, but all of the providers of how do we work with psychiatry? How do we work better? As I think a number of people know, usually the first instinct is like, oh, well, help me with medications. That's what psychiatrists do. And yes, we are happy to do that. But there's a lot we can provide. So we can help assess and evaluate, providing that diagnostic clarification that can be crucial for remission of symptoms and effective treatment. We can provide a biopsychosocial wellness conceptualization. So really understanding, putting the patient at the center and really understanding what are all the variables that are causing this patient's manifest symptoms. We can then prioritize treatment and planning. So, is the medication going to be the most important, or actually with trauma, we're going to really need some therapy on board. The medications will help mitigate, but if we don't provide enough education to allow the patient to understand the importance of therapy, they're going to really never get symptom remission. Again, medication management, psychoeducation. We start to realize these diagnoses can be so used so commonly amongst the community, such as you're bipolar is a very common one. And what does it mean to actually sit down and recognize that this is the patient's illness? And how did they understand what does bipolar mean? What does it mean for their life? How do we bring in the family to really educate on that diagnosis and what treatment looks like to allow for adherence and maintenance of health? Bridging care and navigating systems, a big deal for psychiatry, right? Trying to establish and navigate these fragmented systems. And then just support consultation discussion, right? Sometimes providers just need a little validation, like, I'm doing this right? Is this medication gonna work? And we're happy to do that as well. Next slide, please. So what does it look like, right? So, obviously, if there were enough psychiatrists, it would just be easy, right? The primary care doctor sends them to psychiatry. This is the old model. And psychiatry just sees them and then they work in these kind of silos. But integrated care is much more complicated. How do we keep it integrated and not siloed? So a couple pieces. So one, what we have is a weekly telepsych virtual hub team meeting. What does that mean? It means that all the psychiatrists meet and they discuss patients of all 7 clinics. Currently it's 3, but it will eventually be 7, along with our addiction specialists. So it means 1, we're all sharing our expertise, right? We're all gonna have unique expertise. 2, we're always refining process. And then 3, we're also recognizing, hey, that's where we will triage. When is addiction needed? And when do we think like, hey, we need to help bridge, or what are the next steps? So that's the first step. Then that lead psychiatrist, actually, let's go to the next slide. Oh, that's okay. There you go. So then what will happen is that lead psychiatrist will have then a weekly, what we call our telepsych huddle. And this is the time for them to meet with the family medicine providers. They can join on to a link whenever they need. The psychologist is always there. And then we also are working to have a telepsych coordinator. So this is a time for an hour to be like, okay, what's going on in this unique clinic, to bring back from the psychiatry hub meeting into each individual clinic. Hey, this is what here's some additional thoughts, while the psychologists and the primary doctors feel back, well, this is what we're seeing and this is what's happening with this patient, or this is how this process is working. This has been so effective that actually I've had some providers ask for, hey, can we have a little bit more of this time? And even if it means not having as much direct patient time, but can we just have time to work through and talk through clinical cases? And, I apologize, Polly. Can you actually just go to the last slide for just a moment? Oh, I apologize. I'll just make it a little complicated for everybody. Okay, well, that's fun. So fine. The slide before, we were just talking about, why is this important? And just a couple pieces I'll just quickly mention is, we all recognize that burnout is such a big piece of issues that are coming up. So how do we actually really try to return fun into medical care, right? Keep it stimulated, allow us to learn. These hour or week huddles allow us to continue to learn, right? The steep learning curve. It allows us to really acknowledge complexity of difficult cases, and recognize distress in patients as well as in providers if needed. It allows for this time of shared problem solving, of mutual support, of respect, of balancing that humility with that confidence. So far it's been a really lovely addition to allow us to be integrated. This last slide I'm just gonna share is, new to the UPL grant is this idea of having addiction medicine. Now we have 0.1, right? So that's 4 hours of an addiction specialist for 7 clinics. So in order to effectively use that time, what we've done is we're triaging through the psychiatrist in the ways that you have seen, but it's also available at the addiction medicine specialists can also see patients as needed. That is going to end my piece, and I'm going to hand it over to Dr. Corey Lyon. Thank you.
Great, thank you, Jacqueline. I'm briefly going to touch on how do we do this implementation and integrate behavioral health services into a primary care medicine environment. So especially as we try to integrate multiple clinics with this model that you've heard about. So the main goals of implementation into the medical setting is to really fully integrate these services and these team members with the clinical team and not just co-locate. It's not a refer and forget model, I like to call it. It's like the physician in the clinic office refers and then forgets about what's next. They kind of like leave those service decisions to the behavioral health provider or the psychiatrist. What we want to do is make it more integrated. So we have to be very intentional and make sure that that structure is built to provide that integration. And so we really want to have a consistent workflow across all these clinics. Each clinic is a little bit different, so there's some flexibility, but we want to make sure that those workflows are consistent and really assure that integration. Knowledge of those workflows. So it's one thing to have it down on paper, but we really need to make sure that all team members really understand these workflows and the spectrum of services that are available, and then how do you use these workflows to fully integrate. These are team-based care models, and every team member has to understand each other team member's role clearly in order to fully integrate. Okay, Polly. So what are challenges to that? It is very easy to underestimate how difficult it is to integrate and how difficult it is to initiate new clinical workflows and processes. So that's the main thing. So we have to make sure these workflows are actually working. So within multiple clinics, there'll be some differences, and some differences are needed, and some clinics have different experiences. But you have to mobilize these new workflows, and so that involves, what is your implementation strategy? How do you educate the providers on the hows and the whens and the whys to utilize behavioral health resources? And some of these clinics, this is the very first time they're going to have any sort of integrated team member. So we have to make sure that they understand how to use these workflows and how to make sure they stay integrated. All clinic staff have their own workflow responsibilities. So that's whether it's through referrals and scheduling, and then technology, who's going to help with the technology in order to do these telepsychiatry visits and appointments. And then there's the other challenge is the health system that may be supporting us. They may have different priorities. We have to go through the health system in order to get the IT technology up and running. So that relationship is very key, and we have to continue those dialogues and strategies to make sure that we're able to utilize the support our health system provides. So our planning process is trying to standardize our clinic workflows. So each clinic understands how these integration models work. Really the importance of having an embedded psychologist locally, either in person, and sometimes at this time they'll be there embedded but be virtual. And we develop systems for warm handoffs. How do we introduce a patient to our psychologist during the clinic visit? And then there's a stepped approach of care. Sometimes we want to start with the psychologist, and as they're working through, they'll realize we need a higher level of care with assistance with diagnosing or assistance with medication management, and maybe we'll bring in a psychiatrist or addiction medicine. And the assistance of whether through psychology or psychiatrist helping with that diagnosis. Communication structure is important. To be integrated, we have to have the communication. The communication has to go back to that primary care provider, because the goal is that they are a part of that plan and helping carry out that plan. So that communication has to be clear, and each roles be very well defined. And then identifying what works for the system, but also what works for us. Sometimes we have to be able to push the health system a little bit, and say, but in order for us to be integrated and not co-located, these are the processes we need. These are the support we need. And finding those and then being able to have those conversations. Okay, that is mine. I think the next slide will be about evaluation and Bethany.
All right, hello. The purpose of our evaluation is really to help support this ongoing iterative quality improvement process, with the primary goal being to figure out how can this model be sustainable within our family medicine practices? How can it be efficient? How can it be effective? And how might we be able to support further growth and refinement of the clinical model? Our evaluation frameworks from an outcomes perspective is the quadruple aim. So looking at elements of population health, quality of care, patient experience, care team experience, the elements of burnout that were mentioned earlier, as well as the cost and value of care. Is this something that can be sustained financially? And so the feedback from the evaluation, which we'll be getting on about a quarterly basis in a variety of different ways, will be really critical to appropriately modify and adapt the service model to fit these individual clinic environments. Our team today has described a wide variety of components that may look really different in each of the different practices. Can we begin to learn what aspects of these different clinic environments are best suited to one modification, adaptation, to workflows or to roles, so that we can provide that information to other practices who may be wanting to tailor the implementation or delivery of services to their patients according to what's going to work best for them. Next slide, please. So some key points. So we're doing what's called a multi-level evaluation. So really thinking about the patient perspective, the provider practice and staff perspectives, as well as the institutional perspective. What do the organizational leaders, what do the health system leaders see as a value? What do they see as a return on the investment? What do the funders see as a return on investment? And so really thinking about all those different levels. And we're using what's called the RE-AIM framework, as well as the quadruple aim, to help structure our evaluation. RE-AIM stands for REACH, which is, are the patients that are expected to be receiving services actually getting them? Effectiveness, is it improving our mental health outcomes, our behavioral health outcomes? Adoption, which is, are the providers within the practice taking up and using this model? Implementation has to do with fidelity and consistency of delivery of the services as intended, and maintenance refers to, are the effects that we're seeing persisting over time at the patient level and at the provider and practice level. We'll be looking specifically at the ROI, or return on investment, of the services that, in order to better understand the financial sustainability of the service model. And again, looking at multiple different levels of perspectives of whose return on investment might be the most likely to succeed in the long run, or what set of different strategies might we use for sustainability. And ultimately, our goal is to inform organizational decision-making, so helping to support this team and our family medicine and psychiatry departments in particular, the decisions that they'll be making about how, when, where, why, to sustain services and to spread them to other settings. Next slide. As I mentioned, our evaluation framework is RE-AIM. We're also supplementing it with something called Prism, the Practical, Robust Implementation and Sustainability Model, which gives us a sense of the different aspects of context to look at. So I mentioned that we'll be assessing modifications and adaptations as it relates to different aspects of practice, culture, and context. And this PRISM framework gives us a sense of what are those contextual factors that we need to be evaluating. So thinking about aspects of the external environment, like the policies, the resources, the guidelines, the incentives that are at play that we need to align with, as well as elements of internal context, the multi-level organizational and patient characteristics. What are the populations of the patients like within each of these different practices? How are they similar? How do they differ? What are their perspectives or their values as it relates to this particular service model? Do they like it? Are there aspects of it that they like more than others? Are there strategies that they see as particularly useful or relevant to them? And then what's the implementation and sustainability infrastructure within these practices? How are they set up for change? What's the culture of change? Are they used to change? Are they overwhelmed with change? How are they with the team-based approach to care? How are they with communication? What's the leadership like? Who are the champions in the practices? And how do we, again, align with that? Because ultimately what we're attempting to do is identify fit and interactions amongst all of the intervention or service components, our implementation strategies, what Corey just described around all these different ways of changing workflows, of changing mindsets, of changing culture around team-based care. Really integrating with that inner and outer context. What support are we giving practices that align with their resources and interests and values? And how are we assuring that the sustainability aligns with those external policies, guidelines, and incentives that are at play? And then refining over time those different re-aim dimensions. How do we prioritize? Where are we struggling? Have there been successes? And so ultimately, again, what we're trying to do is find fit amongst the context, the service model, and the sustainability plans for this model. So as I mentioned, we'll be doing the evaluation over time, over the next few years, doing a lot of surveys and interviews with practice representatives and organizational leaders, helping to support process mapping, helping to generate communication plans, helping to set priorities around re-aim dimensions, helping to clarify roles. And that's what we'll be doing through this winter. And then in year 2, which is the next slide, 2 to 3, we'll be continuing to do surveys and interviews with practice representatives as well as with patients. We'll be also assessing the patient's value proposition. What are their perceived benefits? What are the resources required for them to access the different services? We'll be looking at administrative and claims data to evaluate the return on investment in different ways of aligning with incentives to the health system, looking at revised process maps, understanding how do the roles change, how do the workflows become more refined and more efficient over time. And how we do this is we do small scale analysis and prepare reports, which we call learning memos, that are provided to the operations team and department leadership to help inform their decision making and brainstorming about how to address any challenges and how to lift up successes. And I believe that's it. I'll turn it back over, I believe, to Polly to finish this up.
Yes, and finally, we'd like to just say that our funding for this project was provided by CU Medicine with support from the Colorado Department of Healthcare Policy and Financing.